Our next speaker is Dr. Janaki ma'am. The topic is Window of Opportunity Theory for the Early Start.
Good morning, all, and thank you for giving me this opportunity. You must have read name of Dr. Riti Mehra in the program, but she's occupied somewhere else. So I'm the person who will be talking about this subject, and it is very near to heart subject for me, because that is where we can practice and we have our patients treated. So thank you, organizers and madam, for giving me this opportunity. Today's topic is window of opportunity theory for early start, that is about hormone therapy for menopause. The question is it effective? What are the problems? I think madam has elaborated so many things, so I'm not going to go in detail in that. Millions of women face health challenges beyond menopause worldwide, and a significant proportion of them live in India. So it is important to maintain positive post-reproductive health, prevent disease, and reduce mortality rate and improve the quality of life. All four are important. Prevent disease, reduce mortality rate, and improve the quality of life. For that, we have to work on this topic. We know about the changes in female reproductive cycle after menopause and perimenopause. Reduced estrogen impacts many organ systems, resulting in wide-ranging menopausal symptoms. Morbidities related to age and menopause hormone therapy are cardiovascular morbidities, cerebrovascular morbidities, DVT, pulmonary embolism, dyslipidemia, diabetes, dementia, breast cancer, endometrial cancer, ovarian cancer, cervical cancer, osteoporosis related fracture. So we have to be very careful when to give and when not to give, because you can prevent something, but you should not give something with menopause hormone therapy. That is very important, and that is where we have to learn. Not all women experience one pattern of estrogen decline over the menopause transition. They start with menopause symptom, with vasomotor symptoms, irregular periods, sleep complaints, depression and anxiety, and later on they have problems with sexual health and osteoporosis. So this is the transition. Menopausal transition is associated with an increased risk of cardiovascular diseases. Traditional CVD risk factors are common during menopausal transition, and post-menopausal years, this can partly explain the augmentation of CVD risk among the women. Decreased ovarian function and estrogen production are associated with urogenital changes and sexual dysfunction also. Decreased ovarian function and estrogen production are associated with loss of bone marrow density also. So, where do we stay in menopause hormone therapy? What is important? Post-reproductive health is a challenging issue that it is surrounded by many controversies. Menopause hormone therapy has witnessed a rise and fall over last several years. We do understand that comorbidities incidence rises beyond menopause, and we need to prevent that. But when MST was used universally, risk-benefit ratio became unfavorable and we had to stop. Hence, the use of MST dropped drastically. But newer studies have introduced the concept of window of opportunity, wherein MST does not have harmful effects, but in fact it prevents comorbidities associated with menopause. We have to focus on prevention of menopause and menopause-related comorbidities. Prevention of menopause and menopause-related comorbidities, they are mainly cancer, osteoporosis-related fractures, cerebrovascular event, pulmonary embolism, dementia, breast cancer, and endometrial cancer. So, cancer and osteoporosis we can prevent, and as well as it can be done with menopause hormone therapy also. So, what is important? Since incidence of heart disease in women is higher after menopause, exogenous hormones containing estrogen and progesterone were used with the aim of reducing the risk of heart disease. Menopausal women were prescribed MHT universally, but the results were not favorable in Women's Health Initiative. Use of MHT in treatment of menopause decreased dramatically because of this WHI report in 2002. What was wrong? Average age in that study was 63 years. 12 years since menopause, 50% were smokers, 50% were overage, and 30% had previous MI. 26% women had never used prior use HIT. Only CEE and MPV, that is used. Paper only written by small group of investigation. Results were sensitized and generalized, so people stopped prescribing HRT. Further result with younger women, estrogen only HRT were not picked up. But after WHI, 13-year follow-up was done. MHT was not associated with risk of all-cause cardiovascular mortality and cancer mortality. That was confirmed in 2017. So these are the data. I am not going to go in detail because I have only 10 minutes. What was follow-up of WHI? Estrogen progesterone replacement therapy HERS study was concluded that MST is not recommended for primary and secondary prevention of coronary heart diseases. Even though the WHI trial was stopped after 7 years, 23,347 postmenopausal women aged between 50 to 79 years were included in the trial, were followed up for extended period of 13 years without treatment, and further analysis of data gave many insights. What was the dilemma? Universal use of MHT is now not recommended anymore. So how can we select women for prescribing MHT? To control symptoms, to prevent comorbidities, and to give them better quality of life. What strategy we should be achieve to get the best balance between risk and benefits of MHT? That is where we have window of opportunity theory. A concept of timing hypothesis or window of opportunity has been introduced for the initiation of menopause hormone therapy. It indicates that menopause is the best given immediately post-menopause for shorter duration of time. MHT started many years after menopause and continued for long duration thereafter. It has been associated with more side effects. WHI data analysis showed that MHT was not associated with higher complications among younger age group, that was 50 to 59 years when analyzed separately. Early initiation of MHT post-menopause is associated with lower CHD risk in women aged less than 60 years of age. In a meta-analysis of data from 23 studies, it was found that MHT is associated with lower cardiovascular risk and 32% lower in younger women. So we can prescribe in this window period. The Danish osteoporosis prevention study also initiated in 1990 for a duration of 20 years. It was partly randomized study, included normal and healthy postmenopausal women. It concluded that MST has a beneficial effect on coronary artery disease than rather worsening it. The study supported the fact that hormone therapy initiated immediately after menopause up to 7 months post-menopause reduces the mortality due to coronary artery diseases. It also demonstrated reduced incidence of heart failure and myocardial infarction. Most importantly, they also proved that the risk of thromboembolic event, stroke or cancer was not increased with MHT. The KIPS trial. The KIPS was a double-blind randomized placebo-controlled multi-centric trial, and it was also found that it assessed the progression of carotid media thickness and atherosclerosis using the coronary artery calcium score. They found that the use of MST did not worsen the carotid intima thickness and led to higher incidence of atherosclerosis. Elite trial also supports the timing hypothesis. So we have all these trials, 2017 Cochrane collaboration systemic review also concluded that MST for primary and secondary prevention of CVD or for prevention of cognitive function was not indicated. So only for the prevention of other symptoms, not for cognitive functions, we can give menopause hormone therapy. It should be noted that only 30% of women from this review were 50 to 59% old, and the analysis of these data shows that younger women showed at the time of 2 years only venous thromboembolism was increased. It was very rare. So what is the global consensus? As a global consensus, MST does reduce the risk of cardiovascular disease only if it is used in the period of window of opportunity. Hence, to reduce the coronary heart disease risk and overall mortality in women, the best strategy would be to initiate hormone therapy within 10 years of menopause and or before 60 years of age and continue for short duration of time. MST after 60 years of age has a risk as it is as advancing age, the vasomotor lumen gets partially obliterated with atherosclerotic plaque. MST will make the plaque unstable and it reduces the vasodilatation, which is eventually leads to the increased risk of cardiovascular diseases. So this is the in conclusion, for all over mentioned studies that indeed indicates that initiating MST early before atherosclerosis is established will help delay its further progression. Do we have time? Okay. So what is more advantage? Vasomotor symptoms, as you know, it is well established that MST, including tibanol and benzodiazepine, is very effective in controlling vasomotor symptoms associated with menopause at any age. Current data seem to indicate that vasomotor symptom could be a biomarker for cardiovascular disease, and perhaps this will help the selection of patient for longer duration of menopause hormone therapy because of this window of opportunity. Vasomotor symptoms and osteoporosis. Is there any correlation? Women with moderate or severe menopausal VMS have lower bone marrow density at the femoral neck and lumbar spine and increased rate of hip fracture during more than 8 years follow-up compared with the women who did not have MS. So we can focus on this symptomatic women for the prevention of osteoporotic related mobility and mortality. It is well accepted and proved that various randomized control trial MST including tibolone lowers the risk of fracture related to osteoporosis in postmenopausal women. Mood changes and MST. MST helps improve mood changes in early postmenopausal women. MST may also be useful for perimenopausal women with major depression. Some women with suicidal tendency feel better with MST, but antidepressant therapy must be the first choice in this setting. It cannot be first choice is MST. They should be given antidepressant first, and if they need, then they can be given MST also. Reducing MHT-related comorbidities, that is very important. Estrogen alone, MST decreases incidence of myocardial infarction and also decreases the all-cause mortality when initiated in women younger than 60 years of age and within 10 years of menopause. But estrogen alone therapy is not recommended when the uterus is intact. So addition of progesterone is mandatory to prevent occurrence of endometrial cancer. So the type of hormone therapy receives, that is intact estrogen plus progesterone, hysterectomy, endometrial ablation, only estrogen, and endometriosis, estrogen and progesterone. All estrogens are not same. She has already told that, and all the progesterone also not same. So we have to consider all this. So what is global consensus? MHT. Okay. This is last slide. MHT should be used in smallest possible dose and shortest possible time. An early start of MHT in selected women in the window of opportunity is the key to have best balance of risk and benefits for preventing all comorbidities related to menopause and MHT. Thank you.
Thank you, madam. Thank you, madam, for the wonderful deliberation. You have well explained that right woman, right time, and right therapy. And that is also the within 10 years, that is below 60 years and 10 years of menopause. This is the window of opportunity. This 10 years is the window of opportunity. If we start MHT during this period, so that will help to prevent cardiovascular problems, vasomotor symptoms, and VT is also reduced. So we should start, we shouldn't be afraid of giving MHT, and we should start it as early as possible, just after menopause, and within 16 years it will be the most effective therapy. Thank you very much, madam, for your wonderful deliberation. Thank you, ma'am.
Doctor, one word I would like to change, that shortest possible dose, not for the shortest duration, but for the intended duration. Am I right, Dr. Jyoti? And one more thing about the therapy, it is combined therapy is better than sequential in preventing the endometrial cancer. But the thing is, it increases the risk of breast cancer because the progesterone is given for the longer period. No, let me complete. So that is why we have come up, because it is a progesterone which creates a problem. So that is why we have come up. So type of progesterone also matters.